I'm an ophthalmologist and a surgeon. I'm working in Vienna at the clinic Landstraße. It's a general hospital with different departments, and I'm doing their vitreoretina surgery as well as cataract surgery and some oculoplastic things. So just to know, who is performing retinal surgery in this group? Okay, cataracts or starting cataracts, great. And the rest is also doing surgery or just medical retina? Okay. So my main topics will deal with the retina. So the first part of my talk will include macular disorders like membranes and macular holes. And the second part of my talk will explain retina detachment cases, which procedures we have, and what is the standard you have to consider when you have some patient with a detachment. So the first part is epiretinal membranes. I think you all know that the main cause for developing a membrane is idiopathic. So it's an aging disease. Mostly female are getting membranes. The age is mostly over 70 years, but you can also develop it if you are diabetic, if you have high blood levels of cholesterol, or if you had something like a vascular disease, an occlusion, then you can also develop a secondary membrane. Due to the diagnostic tool, the OCT, we learned about the behavior of the membranes and how they can look like. So if you look at the left picture, you see this is a more adherent membrane with a thickened central retinal, and here you have a more focal membrane where the foveal contour is not so bad. The normal eye has a central retinal thickness of 150 micrometer. In a case with membranes, you have more than 400 micrometer, and after surgery, it's not less than 300. So you can see, is the foveal contour still there, or is it not there anymore? You can also see, are there some cystoid spaces, or is it more regular? So we learned a lot from the OCT. And we learned that two important layers are mandatory to recover a good vision. The first one is the so-called ellipsoid zone, and the second one is the intact membrana limitans externa. So formerly it was called the IOS line, but it's renamed. If you have a patient with this condition, what's the cause of the condition? So normally the majority of these patients are without any symptoms. They are doing fine or sometimes even better, and half of them still keep the good vision. There's only a little progression, so only a bit more of 10% develop a decrease in vision. And when the membrane is going more fibrotic, then the vision can drop to less than 50% or around 0.3%. But you don't see a lot of patients with a severe vision loss. Besides the vision loss, you have the occurrence of metamorphopsia. If the center is located, you can also have diplopia, and the patients have difficulties if they go downstairs a stairway, they have problems with the 3D vision, or if they are playing tennis, they don't see the ball anymore. And mostly they notice this change when they are doing reading or computer work. So if the patient is symptomatic or he has this kind of metamorphopsia, we can consider surgery. I don't know which gauge systems you have available at your places. We have 27 gauge, 25 and also 23 gauge. In these easy cases, I'm happy that I can use 27 gauge because it's very tiny and the wounds are tight, and I really like it to do this way. But 25 gauge is also very fine, and even 23 gauge is a good option. If you have a patient who is older, so if he has signs of cataract, we should discuss with him, should we do a combined surgery? Because we know that when we do vitrectomy, the most common complication is cataract formation. And here you see that the development within the next 4 or 5 years after surgery are very high, so more than 65% are developed cataract, and even more, it's nearly 100% if you use a tamponade like gas or like silicone oil. So this is a thing you have to talk to the patient. Studies have investigated, is it safer to do the combined procedure or to go on with the vitrectomy first? And they didn't find a difference regarding the safety and the outcome, but in diabetics, an anterior uveitis was more common than in a healthy case when you did the phaco-vitrectomy, and sometimes you can develop some synergy here. This happens in a little bit more younger persons, and this may be a little bit of a complication also. But if you do a phaco-vitrectomy, the recovery, of course, is faster and it's cost effective. So you only have one inpatient or outpatient procedure, you have only one surgical procedure and one kind of anesthesia. There's also discussion of the refractive outcome. So in a series, it's 15 years ago, we did 20 gauge vitrectomy. This is the orange trocar color. And we did larger sizes of the clear cornea incision. We did 2.8 millimeter. And in these cases, we found that the patients after a combined approach are getting more myopic. Nowadays, with the tinier incisions, also the cataract incision, it's not so big anymore. This is, how can I start? Just press? Press next slide. Okay, this is a combined case. This is the Alcon constellation. This is 27 gauge, the purple color shows you this. This was a female patient with an epiretinal membrane. I did a standard cataract surgery and just the hydration. Now you see I'm cleaning the periphery, and first I did a core vitrectomy. And this is an interesting OCT tool where you see there's the membrane. And we are mostly lucky that we have some fellows or residents in our OR, so they help us with the indentation. Now I put in a blue dial, remove it, and this is the forceps. To remove the membrane in 27 gauge, you can also use the finest loop, but I prefer to do it directly with the forceps. These bleedings are complete harmless, and mostly the first day post-op you don't see them anymore. I do sometimes a double staining, and here you see the macula was free, but you have some dumplings from the peeling. We have different staining tools. So these are the blue series, including membrane blue or membrane blue dual. Membrane blue is just staining the membrane, but the membrane blue dual is a combination, and they also stain the ILM. We also have triamcinolone. This is a negative staining because it stains the vitreous or the posterior hilid, but you can also do peeling with it. You can use the brilliant blue G, it's just ILM effective. And we also have the controversially discussed green dyes, indocyanin green or infracyanin green. For the peeling, we have either the forceps, or if you use larger gauge systems, then you have also the Thanos scraper. It's a diamond dusted scraper where you can make a tiny fold and then you can remove it with the forceps. The question is, do we have to peel the ILM, or is it sufficient to peel the epiretinal membrane? We found out that if we do a standard epiretinal membrane peeling, we also remove parts, sometimes more parts of the ILM, so in between 40% of the ILM, and studies didn't found any effect if you do an additional ILM peeling. So you have two options. You can keep it there. If you see it's fine, it looks smooth, then I wouldn't go extra for the ILM. But if it's still wrinkling, I like to double stain and have a look if there's still a residual. So what about the recurrence rate? This is the only thing which affects the ILM peeling, because if you do it, you reduce it from 3 to 12% to 5% in idiopathic membranes, and even more in secondary membranes due to trauma and inflammation, and in younger patients. So this is the pro for ILM peeling. On the other side, if you do an additional ILM peeling, what about phototoxicity, the RPE nerve fiber damage, and also the dyes are controversially discussed. They have investigated ICG, and they found that this might cause some visual field defects and cause some optic atrophy. So if you use it, if you don't have any alternative dyes, you should use it in a low concentration and not longer last it in the eye than 10 seconds. Then it's quite safe. But if you have an alternative, I would prefer the alternative. And the second is the trauma which you cause due to the macular area during surgery. What's about ochriplasmine? There was a lot of investigation regarding membranes. In membranes, it's not recommended. For vitreomacular traction and for some holes, it's different. This is a very nice tool. We have it in one of our clinics. It's an intraoperative OCT, so you can see what you're doing during surgery and how the macular area is behaving. This is a size rescan, and you see it in the monitor like this, and this is the screen. These are some samples from the peeling. So the first patient has, I think, a membrane, yes, 66 years. Here you see the OCT, you see it's not too adherent. Here you see the membrane peeling, and you can see the membrane and the traction. So which I learned from the OCT is that I don't peel like this anymore. I try to peel more horizontally, not to do too much trauma. And here you see the results after peeling. This is also a female patient. She has a macular hole, and after staining, you see we do the ILM peeling. It's quite a large hole, and I also changed my routine. I don't tear the ILM backwards. I press it to the edges of the hole, that I don't enlarge the hole sizes. And here you can nicely see the trauma you are creating, or the less trauma you're creating. This again is a membrane case. It's a small membrane, you see it here. It's a male patient, and you see it's also again quite adherent, so these small hemorrhages are not caused by the forceps, it's due to the peeling procedure. And here you see it's quite smooth, and a little bit of ILM wrinkling is there after peeling. So this tool is also nice if you do some surgical training with your fellows so they also can see it, what happened during surgery. If you did surgery, the results are very well. So most of the patients, more than 60 to 90%, have a visual improvement of more than 2 lines. And you can also tell your patient that not the first months or the first 3 months are important for the recovery, but they can also gain more vision within 6 months or 1 year. And this is also the same for the metamorphopsia. They won't lose it completely, but mostly they report it's better for them, or it's not so dizzy anymore, and they improve regarding their binocular vision. The prognostic factors in these cases are a quite good baseline visual acuity and fresh symptoms, so less than 6 months. And the outcome is better in older patients and if the reason is idiopathic. You have the important lines again, the intact ellipsoid zone and the intact membrana limitans externa. The other OCT parameters like central retinal thickness, ILM removal, how the fovea looks, or other intraretinal cysts don't affect the vision. What they found is that the length of the photoreceptor outer segments is important for the visual recovery. So before surgery, it's thicker than after surgery, and during the visual recovery, it's getting again thicker within 3 months. And the outer foveal thickness doesn't play any role. But it's also interesting that these cases with pseudohole formation and membrane, and here with, you don't see it very well, but there is also a splitting of the inner retina. These cases are also doing better with or without surgery. And another important parameter is the inner retinal thickness. This means if you have a case like this, it does better than you have a case like this or like this. So a smaller inner retinal thickness is also a prognostic factor for a better outcome. The outer retinal thickness not. So what can you tell or what can you learn if there is a vision loss and or just metamorphopsia and you have the diagnosis in the OCT, then surgery is indicated. The best outcomes are if the vision is not too bad, if it's quite new, or on the other hand, if the epiretinal membrane has a progression of symptoms, that's also a good start for surgery, and the integrity of the ELM and the ellipsoid zone. And I like to do these cases with 27 gauge, if necessary with cataract surgery. I use membrane blue dual because it helps me to see a lot better if I have to do initial ILM peeling, and you can use double staining or even the intraoperative OCT, but mostly you don't have it with you. These are some pictures with the intraoperative OCT. Here you can see there's a small place between the ELM and the membrane. Here you can perfectly start the peeling. Here you see there is still some residual. And this is also interesting, as I showed you before. I always thought that directly after the peeling the surface looks smoother, but it absolutely looks quite the same. And this stays for about 2 to 3 weeks after days after surgery, and then it's getting a little bit smoother. So what you can also consider is to do in these cases where you have a lot of ILM folds, some air bubble, just to massage the retina. And here you can see the trauma, the traction, how you remove the membrane. Are there any questions to the membrane part? The indications to outcomes? No. Okay, then we can go on to quite a similar part, but with a worse prognosis without surgery. We are talking about macular holes. So again, it's affecting older patients mostly, or you have a young patient after trauma, of course, it can also develop. Again, females are more affected, and the chance that there is a risk for the second eye is also there. So it's 50% in 5 years. And it's interesting, these cases rarely have a complete posterior PVD. So you see an OCT and you think, okay, there is a PVD. It normally is not really if you do the surgery. If you have no PVD, there is a higher risk to develop a macular hole within 1 year. So this is the development. You have tangential and anterior-posterior traction, and there happens a splitting of the inner retinal layers. These are the cystoid spaces. The perifoveal vitreous detachment is there, but the vitreous is still adherent at the optic disc and also at the fovea. You don't see it here very well. The next steps are that the that the cystoid chambers are going to the outer retinal layers, and then they develop a flap or a roof, and here the vitreous is still adherent, and this is a so-called macular stage 2 hole. Then it's getting to penetrate, and you have a free operculum, and if the size is less than 400 micrometers, you have a stage 3 hole. Here there is still an attached vitreous, and this is the last grade. This is when the hole is getting bigger, more than 400 micrometers, and in these cases, mostly there is a complete posterior vitreous detachment. So what is here the problematic for the patient? The first hole I showed you, the small one, it's mainly asymptomatic, but stage 2, 3, or 4 holes have this metamorphopsia in the center. So all is a little bit compressed and it doesn't look very natural anymore. And it's again the central vision, which is the greatest problem for them. But they also see it in the distance visual acuity. In these cases, the visual acuity prognosis is very poor. So you see that only 5% keep a good vision, and it's getting down after the whole procedure to 0.05 until 0.2%. This is summary that in macular hole stage 1 you don't have a great progression, you have more regression, and their surgery is not recommended. But in all the other stages, you see in the macular hole stage 2 there's an enlargement of 75%, in the 3 group more than 50%, and both groups do better with surgery. But also in the big stage 4 holes, where the enlargement is not as big anymore, you improve if you do surgery. It's not a big step, but normally if you have a patient with 0.1 vision and you are able to close the hole in quite a short duration, then he can go to 0.3 or 4. Again, we have the small gauge surgeries available, and if you have a certain age, the combined surgical approach. Here the results are quite different. So some are reporting that the closure rate is about 73% with improvement in 40%. Other studies closed their holes in more than 90%. And the vision is also quite good, 20/40 in 30 to 70%. It can also happen that after surgery, there is a late reopening after 1 or 2 years. Then of course you have to go again for surgery, and it also be very rarely, so it's in 1 to 5%, that not surgical treated macular hole can spontaneously close. So I saw it twice, so it's good to do an OCT before you go to surgery again. It shouldn't be too old.
Excuse me, maybe I missed. What's the difference between those cases? I mean,
This is just that the macular hole closure rate was higher in the other group. No, it's the same. It's just a group study. So you have a high closure rate, and it's in between 70 to 90, 95%. Here, ILM peeling is recommended in macular hole cases because the anatomic success rate is reported to be higher, but the vision is the same in stage 2 or 3 holes. Here, again, it's also a trial, but they recommend that it's not important to peel the ILM, and you have the anatomical outcome and the functional outcome comparing all. No peeling, ICG-assisted peeling, or trypan blue peeling. So this is also a randomized trial on macular holes, stage 2 and 3. So they don't know what you should really do. These are the cases with the different dyes. So here you see the first one is the BBG. It's the ILM dye. It's a light blue, and for me, when I used this, it was not so easy to see the ILM very well. Here you see the OCT. It was a macular hole. You can maybe make a small tear and then do a double staining, and then you see it a little bit better. The ICG in this concentration of 0.05 has a better staining effect, and if you're used to use this, it's hard to use other dyes. And here you see that's a nice green tissue, which you can easily remove. So when I started to do the peeling, I started with ICG, then I had to do it with BBG, and then comes the membrane blue dual, and this is one of my favorites because it's darker from the blue, and it stains both, as I told you before, the membrane and the ILM. And you really see it much better than with the other blue dyes. And I do the peeling using the corneal lens to have a better 3D vision. And here you see it's a nice blue layer. There's also another one, the ILM View. It's also very nice, and it stains also both. So the blue dyes really improved from the quality. Regarding ICG, you can see the autofluorescence, and you also see the remnants after 6 months. So this was also the reason why it was not so seen very well in macular surgery. you have the chance to do some visual damage, the visual field defects, and alterations of the pigment epithelium, as well as to cause some optic atrophy. So as I told you before, very small concentrations in a fluid-filled eyes and only 10 seconds exposure time. Infrathionein green, which is also available, might be a little bit better. In the United States, it was a big problem because they didn't have access to blue dyes, so they did the green dyes very long, and they even do it very long. But in this mixture, it should be quite safe. Which kind of procedures do we have? This is the inverted ILM flap technique. It was introduced from Michalewska and her colleagues in 2010. Large holes where you peel the membrane to the edges, and then you make a flap to cover it. And these are the OCT scans after the procedure. This is a video again from an inverted ILM flap. So you see we put the ILM towards the margins of the hole, but they should be connected and not be disconnected. If you use the inverting technique, then you cut or trim this ILM flap, and then you put it into the hole. In these cases, I like to use some air bubble, that it's more stable, and the air bubble don't last very long in the eye. I don't go for gas in these cases. This is another technique. This is where you just keep a little bit of the ILM at one edge, and then you make it like a macular plug. You can also use some viscoelastic to make it stable. This is another technique of a free flap. This is very complicated because sometimes the free flap is going away, but you can also take some visco that it stays in place. And you have different autologous retinal flaps. You can also use blood or autologous platelet concentrate for larger macular holes or for therapy refractory macular holes. Which about the air? Air I would only use in flap cases, because if I only do an ILM peeling, I prefer to use either a mixture of SF6 and air or C2F6 and air. Silicone oil may be necessary if you use an autologous transplant. So in a macular hole which is very atrophic or very large or didn't recover after the first surgery, or if you have a detachment caused to the macular hole, then silicone is also a good option. But otherwise, I wouldn't go for it. What about the postponing? Should they position after surgery, yes or no? Again, they don't know. Some tell us use long-acting gas fill, which helps. Others say it's better in large holes to let them position. This is a, sorry. Yeah. You can use ochriplasmin in small holes, which are less than 250 micrometers. The patient should be phakic, and there should be no epiretinal membrane. Otherwise, it's a contraindication, and the traction should be less than 1,500 micrometers. And then there is a high anatomic success rate that they close without surgery. But if they don't develop a closure, you should go for vitrectomy within 4 weeks. So macular holes are well suited for surgery if you have a stage 2, 3, or 4. Again, the short duration, less than 6 months, small holes, and a macular hole index of more than 0.5. This means this large dimension is better than if you have a flat atrophic hole for the closure rate. Again, the best outcomes are if the integrity of the ellipsoid zone and the membrana limitans externa develop. So here you don't have any layers left. This has a very poor prognosis, whereas this case looks better, and even this case does good. And normally you see a small irregularity after surgery, which may still be there, but it can also go away. And they normally do not affect the central vision very much. It's unclear which dial we should use and if we should position the patient. You can see if you have a macular traction, a vitreomacular traction, when you do the peeling, do you create a hole? This is very nicely in the intraoperative OCT, and then I would of course go for gas, but in these cases I would go for gas, just to be on the safe side. You can see, is it still open? Do you need a tamponade? And these are some surveys of the American Society of Retina Surgeons. So when you have a patient with a symptomatic vitreomacular traction and he has a small macular hole, would you go for surgery or would you observate this patient? So you see that the majority of the surgeons would go for surgery. So what do you do if you do a vitrectomy and a membrane peeling? Although no studies are evidence-based, most do an additional ILM peeling. This is regarding the size. So if you look how big should the ILM peeling be, mostly it's in between 1 and 2 or even more than 2 disc diameters. And here you see in the US the indocyanine green is more common than in the other parts of. Here we have the brilliant blue, and now we also have the membrane blue dual. This is the use of 27 gauge. It was in 2070, so it was at the beginning, and you see it was not very popular because nobody had it. This is a question about the anesthesia. So you see most do it in a block or in a Tennant's block. In our clinic, we do most patients in general anesthesia. I don't know why, but we are used to it, and they get a larynx mask, so the recovery is also very nice and they feel okay. But we never used the block situation. I know we are not the standard. And here you see that the preferred method for peeling is the forceps, followed by the diamond dusted scraper. And here you see that most surgeons do the ILM peeling for a routine macular hole surgery. And the preferred tamponade is either SF6, or this is a more longer lasting, it's 3F8 gas, so it's staying for about 2 to 3 weeks in the eye. And this is also interesting, as I recommend my patient to do face down positioning for 1 week. You also see that most parts are also recommending to do face down position because we believe it helps to close the hose. And this is if you have reopening or if you have an open hole after surgery. The majority of surgeons use a longer acting gas tamponade and do strict face down position. I would try to go for a flap, even it's a free flap, and for tamponade and face down positioning as an additional approach. But other surgical options are not really very common, or weren't very common at this time period. And here you see, this is the new one, it's from last year. Most aren't very familiar with all the other techniques, so it's still the standard procedure with gas.